Welcome to the deep dive. Today, we're peeling back the layers on something really vital, but often, well, kind of hidden: patient safety. Ever stop and think how hospitals actually track when things go wrong? Those adverse events. It's a bit of a silent struggle, honestly.
It really is. Getting a clear picture is tougher than you might think.
So our mission for this deep dive is to dig into a really interesting study. It compares two key ways hospitals try to spot these adverse events. Okay, let's unpack this.
Exactly. We're basically putting two systems side by side. First, there's the one most places use, the Voluntary Reporting System, or VRS.
Right.
And then there's this other approach, more innovative, called the Global Trigger Tool, or GTT.
GTT, okay.
And the core question, the really big one this study asks is, which one actually gives us a clearer view of patient harm? Which one's more accurate?
So traditionally, healthcare's really relied on that first one, the Voluntary Reporting System. It sounds straightforward enough.
It does sound intuitive, yeah. But the reality, the sources we looked at show it has some, pretty critical shortcomings.
Like what, specifically?
Well, the big one is that experts figure only a tiny fraction, maybe 10, sometimes up to 20% of actual adverse events even get reported through VRS.
Only 10 to 20%. Wow. Why so low?
A huge factor is just, human nature. Healthcare professionals, they often worry about repercussions if they report something. Fear is a big part of it.
That makes sense, unfortunately.
And another key thing is the VRS often doesn't really have a good system for classifying how severe the harm actually was. It's often missing that detail.
Okay, so if the VRS has these pretty serious gaps, it really makes you wonder, is there a better way?
And this study points towards one.
Yeah, here's where it gets really interesting.
Exactly. Enter the Global Trigger Tool, the GTT. It's quite a robust method, actually, developed by the American Institute for Health Improvement, the IIHA.
Okay, so how does it work differently?
Well, instead of waiting for someone to voluntarily report something, GTT involves looking back retrospectively through patient records.
Ah, looking back at the files.
Right, and it uses these specific triggers, think of them like clues or flags in the record, to spot adverse events that caused harm. And importantly, it finds them whether or not an error was technically made.
Okay. So it's looking for harm, not just mistakes.
Precisely. And it also systematically categorizes that harm. From E, which is temporary damage needing some intervention, right up to I, which represents severe harm or death.
So this study we're diving into, they use this GTT method in a university hospital's obstetrics and gynecology clinic. They looked at 240 patient files. What did they actually find?
The difference was, it was dramatic, almost startling, really.
Well, dramatic.
Get this. The study found that the GTT picked up adverse events 8.3 times more often than the VRS did.
8.3 times? That's huge.
It really is. Let me give you some numbers. The VRS, it only flagged 10 adverse events in that E's category, temporary damage.
Okay, just 10.
But the GTT, it found 45 E category events plus another 35 in the F category.
And F category means?
That's temporary damage, but needing prolonged hospitalization or, more significant intervention.
Wow. So way more events and more severe ones, too.
Absolutely. Overall, the GTT data showed rates like 47.81 adverse events for every 1,000 patient days. That works out to almost 10%, 9.58% of hospital stays involving at least one adverse event.
That's a truly staggering difference. It just makes you think, doesn't it? If this is happening in one clinic.
Right. How much are we missing overall?
Exactly. But let's talk about the how again. You mentioned the GTT uses these triggers. Can you give us a clearer idea of what they actually look like? What kind of clues are we talking about?
Yeah, and what's fascinating here is the study pinpointed several triggers that were incredibly sensitive. Like 100% positive predictive value.
Meaning if you see the trigger, there definitely was an adverse event.
Exactly. These included things like a healthcare-related infection, complications cropping up after any procedure, really specific abnormal blood test results.
Like what kind of results?
Things indicating serious clotting issues, for example, an APTT over 100 seconds, or an INR level above 6. Also things like organ injury or needing repair, and basically all operative complications. If those pop up, bingo.
Okay, so it confirms GTT is powerful, but this study did more. Right? It actually found new triggers.
It did, yes. And this is really important. It identified brand new, highly specific triggers just for that obstetrics and gynecology setting.
Which tells us GTT isn't just catching what we already suspect. It's helping discover hidden risks we didn't even know about.
Precisely. They found some incredibly specific new triggers. For instance, the use of vaginal dinoprostone, that's a drug sometimes used to induce labor.
Okay, and what was that linked to?
Adverse events like fetal distress and also postpartum uterine bleeding.
Wow.
Another one was high CRP levels. CRP is a general marker for inflammation in the body. And high levels turned out to be predictive of patients needing to be rehospitalized later for infections.
Interesting.
They even identified issues related to things being missed after surgery, like forgetting to remove a gas buffer that's sometimes used in vaginal procedures, things easily overlooked without a systematic check.
So, taking all this together, what's the big takeaway? What does this all mean for patient safety going forward?
Well, it strongly suggests the GTT is a really credible, really effective tool for genuinely improving patient safety. It gives a much, much truer picture.
Especially when adapted, maybe.
Exactly, especially when it's tailored to specific clinical areas, like OBGYN in this case. It just uncovers so much more than the traditional voluntary systems. Now, okay, this was just one study in one center, one clinic.
Sure, limitations exist.
Right. But the implications, the potential for wider use, seem pretty powerful.
It really does drive home that point, doesn't it?
Yes.
That a systematic, data-driven approach like GTT gives you insights that just blow voluntary reporting out of the water.
It truly does. Far, far better.
A much clearer lens on what's actually happening.
And that leaves us, and you listening, with a pretty significant thought, I think.
Go on.
If this level of underreporting, this kind of hidden reality, exists for something as critical as patient safety, well, what other really crucial areas, maybe in healthcare, maybe somewhere else entirely, might still be operating with these kinds of hidden risks simply because, we're not asking the right questions yet, or maybe we're just not looking with the right tools?